Okay. Hi, everyone. We are in the Indiana State University Doctorate in Athletic Training Program. Brittany Tadero.
My name is Bobby Blandingham.
My name is Devin Serrano.
My name is Dustin Anderson.
And I am Kelly Brock.
And today we're going to have a discussion about how epidemiology and our clinical practice as athletic trainers overlap and what our role as healthcare providers is and in terms of overall epidemiology in general. I guess what I wanted to start off with was the fact that trainers, epidemiology and prevention, we do have significant efforts in that, especially with prevention. We had talked about how epidemiology directs efforts to specific groups of people to determine some sort of disease and things as that. So athletic trainers in terms of specific sports, if they're in a college setting, then their specific population may be working with that specific sport. So for example, if an athletic trainer works with basketball, the specific population is basketball, and sort of underlying injury or illness, the athletic trainer can try to determine prevention strategies for in that specific group or prevention strategies for the team as a whole. And something where the athletic trainer has to decide whether they want to direct efforts in prevention within their population, so specific people at risk within their sport, or the entire population in general. So the athletic trainer really needs to determine what is the best approach to use for a specific disease or pathology in order to, and cost effective as well, to prevent any sort of widespread epidemiological effect going on in that population.
Yeah, I think kind of to feed off that a little bit, Brittany was talking about looking at like the collegiate level and an athletic trainer that works with a specific sport. I think coming from drawing some experience off of my end, working in the high school setting, we have many different sports that you can look at, or you can look at a specific sport, or you can look at all your athletes as a whole. And I think you can still do that at the collegiate level. So what are you seeing within all the athletes participating at your university or college? So are you seeing, you can look at it as a musculoskeletal issue. So are you seeing an increase or a high rate of lumbar spine injuries or lumbar spine pathologies, low back pain? And look at what's causing that, and is there anything that I can do to, at the beginning, to prevent that from progressing, or can I take the athletes that are experiencing that and implement prevention strategies to prevent them from increasing that pathology or making it worse, I guess. So you can look at it as a whole, or you can break it down between specific teams. It doesn't even necessarily have to be musculoskeletal. It can be things like diabetes, anything like that, things that you can do to implement prevention strategies into your setting.
I think one thing that's really important is identifying exactly what your population is. You might have athletes who are more experienced than others, and that might be a huge cause and effect that you have to deal with. Personally, I have a lot of athletes who have never played a sport before at the collegiate level, and their injuries are much more than athletes who, for example, are highly trained and are physically prepared for that. So I think a huge thing is understanding your population and what you're going in with. and kind of just adjusting from there.
Yeah, I think that's a good point. I think you all bring up really good points. And I completely agree that athletic trainers have a very, close connection with epidemiology, prevention, and, I feel like our job is all of that, to figure out where a problem is, figure out why it's happening and who's most affected, and then eliminate it, or at least reduce it. When I was reading through the articles, one of them talks about how like secondary and tertiary prevention are the more common ones, just because they're easier, and because it's easier to adapt a person or change a person than it is the environment, or it's more cost effective. And I was thinking about that, and I was like trying to figure out, in what ways in the athletic training realm or in the athletic realm, how do we do each one of those, and like what are the examples of primary routes. And I don't know if Dr. Games talked about it in his welcome video or the weekly update, but working football, I think one that came to mind was just like eliminating contact on certain days at least, so then it at least eliminates the risk of a head injury. Well, not necessarily, but it ideally it would eliminate that potential factor. But like, I don't know, like, can you guys think of like many others where like something is completely eliminated? Because I feel like usually it's more modified. We're normally in like the secondary, realm of prevention. But I had a little bit of trouble myself thinking about primary prevention.
I guess from my end, I don't work with sports or anything else, but like, every day I'm sort of involved with like epidemiology research with the Army, because we have to fill out an injury tracker that comes down from the office of the Surgeon General. And it's just not like every athletic trainer at Fort Sill, Fort Benning, Fort Leonard Wood, Fort Jackson, they all have to fill out the same tracker. And it takes different data points in. So where they got hurt, is it acute, is it traumatic, did it happen in basic training? Like if it did, what events did it happen in? Then we just get certain data points from that one. And what we can do with that is it feeds into, we can do this locally for our battalions, is sort of give them a picture of what's going on when they're getting hurt, what week are they getting hurt in. Like basic training is broken down into 3 phases. Are they getting hurt more at the first, the middle, the end? Is one company hurting people more than the other? Is one company not having as many injuries? Then as the Army as a whole, they get a good snapshot of all the basic trainees going through training at all the different bases. So then they can look at it as, say, Fort Benning doing something that Fort Sill can do, because they're not seeing as many like injuries in this week of training. So it may seem like it's mundane and you have to do it every day, but it's provided me the ability to go and sit into like a command and staff meeting. So like every quarter I'll go in and be like, this is what we've seen. And the last one that I sat in, I've seen like a lot of medial tibial stress syndrome. So I'm sitting there with the company commanders and the first sergeants, and I'm like, we see a lot of people in red phase, which is the first 3 weeks of basic training, sort of like Devon's athletes. They've not really done much, so they're new to physical activity. And we're like, hey, try these exercises before they come see me, so they're not losing training time in the military. It's not losing money by them going to sick hall and everything else. And for me personally, it's made me want to look into Excel, like learning visual basic programming, because the tracker that we use is through Excel. And I think if we can, I don't know who made it, but they're a genius. It's pretty cool to use.
Kelly, I wanted to run off of the primary, secondary, and tertiary injury prevention. I feel like the only thing I can think of for primary, mostly what comes to mind is more general medical issues for prevention in general before it actually occurs. I'm not sure if the example I have right now would be secondary or primary. So right now with the track athletes, we're trying to prevent hamstring injuries from occurring. So we work with the strength and conditioning staff to develop a hamstring protocol to actually prevent hamstring strains from occurring. So this isn't, they already have a hamstring strain and preventing it from getting worse. So do you feel like that would be secondary, or in that case that will be primary prevention?
Well, to me, that sounds like primary, because the main definition of primary is preventing the initial development of the disease or the condition. So if you have nobody that has a hamstring strain and you're implementing this intervention to try to prevent somebody from developing a hamstring strain, and I think that would fall into the primary category by the definition. And
Yeah, I would agree. I would second that, Bobby. Yeah, because rereading, what the intervention strategy for low back pain talks about. It's like it's concerned with taking action to modify or eliminate sources of stress. I think that fits in with the primary prevention, as long as it is with people who have not sustained one. If it's somebody with a history or hamstring strains, I feel like maybe that would be more secondary.
Yeah, I think I would agree with that. That makes sense. And in terms of thinking about something within the sports medicine setting for us, that's not necessarily musculoskeletal, more gen med. So sickle cell. There are no vaccines, so that wouldn't be primary at all for sickle cell. But if someone does have sickle cell, and you're trying to reduce the impact, so that would be more tertiary. I guess the athletic trainer has the oxygen tank available, or making sure the athlete has their inhaler, or things like that, making sure that they're getting enough water throughout the day.
Yeah, I would even think like maybe patient education on sickle cell would be a tertiary one too. They may have never heard anything about it till they got to the college setting. So I think, either pre-participation or that first team meeting, I think, if you talk about it and tell them the signs and symptoms, that might be some tertiary prevention as well.
And that's a good point, Dustin, because in the stress in the workplace article, it did bring up so developing self-awareness and providing individuals with a number of relaxation techniques, or just providing them with the information and providing them with the things that they can do to help themselves. That kind of falls into that tertiary area. Another thing I was thinking about for prevention, at my setting anyways, and maybe maybe Brittany can help me with this one, is, and I'm not sure if there's a relationship between the two injuries, but between the two things, but maybe in preventing lower leg injuries, so stress fractures, stress reactions, MTSS with my track athletes, maybe instead of, because right now they're running inside, like in the hallways, in the gym, and things like that, because of the weather outside, they can't get outside to run. Instead of having them do that during the winter time and in preparation for the spring sport, maybe have them do other things such as swimming or elliptical and things like that as they train for their outdoor sport, because going from different surfaces could cause that lower leg injuries. And we've had lower leg injuries in the past, stress fractures and things like that. So maybe, I don't know if there's a correlation between the two. I mean, I'm sure there is some sort of correlation there, but maybe implementing something like that, I don't know if that falls into prevention, or if that's primary, or if that's something that would actually be feasible.
So in terms of like having an oxygen while they're doing running as well, so not running every single day. Is that what you're meaning?
Yeah.
Okay. So I feel like
Well, I've actually got an idea that I've used in my setting that seems. So my AD warned me, because it's my first season, at my first year, it's that every time the teams go into the field house in the spring, because we have the same issue. You can't get outside because of the weather. We see a huge increase in lower leg pathology. So one thing that I've teamed up with a couple of my coaches with is we're using telemedicine, because like my girls, I know they're on their phones all the time. So what we've started doing is preparing a bunch of basically prehab videos with explanations of different injuries and different exercises that they can do. So it focuses on, doing the 4D for ankle or some hip stuff, things along those lines that they can do on their own time. And the few teams that have started using the field house, they've all said like, oh, this doesn't hurt as much as it used to. I've tried these videos, they seem to be helping. And we've just been kind of going off of that. So it's kind of a way to combine things we've learned throughout of using, telemedicine, which we used earlier in the program, and epidemiology, which we're talking about now.
Yeah, as you were talking, Devin, I was kind of remembering a conversation I had today with some of my supervisors, and we have a tendency to recruit athletes who have had, less than fortunate past medical history. And, we talked to our coaches several times about involving us in that process and allowing us to do some of the screening before they get here and before they, offer them. Because typically a coach will say, hey, I've got so-and-so coming in. Will you do your thing? And they don't tell us that, oh, he's already committed. You can't pull, we can't pull that away from him. And then we find out, oh, he had his ACL reconstructed 2 months ago, doesn't have full extension, or, so many different scenarios like that. And then it's like, well, this person is really at risk. We're gonna have to spend a lot of time doing rehab with him, and it's going to cost the university money, if he gets injured again, and he's more likely to do that. So one thing that we're hoping to do, because we're getting a new coach, is that we will eliminate poor recruiting in general. That way we're not having to do all of this, last minute rehab, or we're not adding people to the roster that are damaged goods, because it doesn't make it healthy for them. It doesn't make it efficient for the university. And, then you're increasing our workload. So I feel like that is definitely an aspect of primary prevention, because, hello, we're trying to eliminate having anything happen. So, yeah, that just came to my mind.
Well, I think that's also a great point, because another thing we've talked about throughout this whole program is work-life balance and understanding our worth. And I think that that's a huge point that you just made. If they bring in athletes that aren't at a peak, or they're coming off a bad injury and you don't necessarily know about it, that costs you guys time and money, and your time is just as valuable as that athlete's and just as valuable as that coach's. So I think not only is it an epidemiology issue, but I think it also kind of plays back into tying everything together that we've talked about this whole program.
Yeah, absolutely. And the AD is involved too, and he has said, this is insane. I don't know why that it was run this way before, and we're going to change it. So I think that he has been able to see, if we were involved more closely in the process, then hundreds of thousands of dollars potentially could have been saved. So I think that they're seeing that, oh, we don't just, do the taping the ankles, braces, the typical stuff. He's saying you guys are actually worth something to us and can save us time and money. So thanks for saying that, Devin. Appreciate it.
Yeah, I even see that on my end, either people get a medical waiver for injuries that they've had in the past, or they just won't tell anybody because they're afraid they won't get in. Then they get there, then it comes to the forefront pretty quick. I've seen some medical waivers for some pretty gnarly hardware in people's ankles. If they've broken a bone before, they had pins and screws, they get a medical waiver, and they're having pain there. I really can't do much. I got to send them up, and they got to get either see primary care and go from there. But again, you think about it, If they did get a waiver, if they didn't tell anybody, I mean, roughly it's going to take around what, $30,000 to get them to basic training. So that's, if they're only there for 2 weeks, that's, you know, about $35,000 that's sort of gone away, you know.
Yeah, I think this whole concept or this whole topic, you can make it as aggressive as you want, or you can make it as simple as you want. So you can start off just looking at, okay, what are my highest injury rates? Why are we getting these injuries, and what can I do to help prevent those injuries from occurring? So you can look at, just like some of the examples Dr. Gaines was given, just look at ankle sprains. What are my teams that are getting the most ankle sprains, or who is getting the most ankle sprains? Is it females or males? Then you can break it down into basketball. Girls basketball is getting the most ankle sprains. What can I do with the girls basketball team to prevent these ankle sprains from occurring? Or you can go aggressive with some of the things that we've been, like Kelly brought up, looking at a whole bigger picture, the athletes that we're actually bringing in. So I don't think it's a matter of there is barriers such as time and things like that, but I think you can make it as simple as you need to be able to accomplish whatever goal that you want to accomplish. It doesn't have to be an aggressive thing like what Kelly was talking about. You can make it as simple as you want, or you can go big and try to prevent those athletes from even coming in. So I mean, this is definitely something that can be implemented by athletic trainers. I think it just takes the effort and people actually knowing how to do it.
Yeah, so basically overall, even as athletic trainers, if they use any sort of EMR that incorporates injury surveillance into it, that's basically you're taking a role in epidemiology, but it's not just if you use it and it goes to like national injury surveillance data. But even if, like for sportswear, what we have right now, at the end of every semester, every year, we look at how many injuries occurred or what was the most amount of injuries that occurred. Just taking in that in your specific population, looking at the actual data, then yes, you're taking a role in kind of the epidemiology, but preventing it from occurring, which is like what we did. We did that same thing exactly, but then we tried to determine that, yes, hamstrings were the largest prevalence of injuries, so then we went a step ahead, talked to the strength staff, came up with a hamstring protocol that they do in weights 3 times a week. And we'll check and see if that's actually helping reduce rate of hamstring strains. But yeah, that's how athletic trainers can play a role as simple as that in injury prevention in epidemiology.
And I think one thing that will probably be hard to do, it goes back to what we've been talking about is time. You know, I think we've been talking about, you know, just doing a year at a time. But you know, it would be interesting, and I think it would be good, you know, if you do it for 2, 3, 4 years at an institution or at your setting, so you can really see what those things are. And that's the good thing about keeping track of it. You know, you can make changes within, you know, 3 months, within a year. But you know, after 2 or 3, you can get a bigger picture of what's going on there. And like Kelly, with football, you know, did it change when new coaches came in? Did it get worse? Did it get better? I think, you know, in the future, you know, if DAT students, you know, sort of set that standard, it leaves like a sort of a springboard for the next class coming in that's covering football to keep going on and everything, so they can actually, you know, within 10 years get a good idea of what, you know, ISU football has, and, you know, did it change or did it get better, did it get worse, and, you know, was it effective with anything?
Dr. Gaines, when he was talking in his PowerPoint, he had mentioned the difference between the prevention and the treatment. Treatment actually eliminates the disease, and the tertiary prevention tries to just kind of maintain it and prevent it from getting worse. Do you feel like as athletic trainers, we do more treatment truly gone away? Is it more tertiary prevention overall, or is there ever the time where we're actually treating it and it fully goes away.
It froze on me a minute, Brittany. I just want to confirm that, were you asking about like implementing prevention, like secondary aspect, and then seeing if it goes away, or like once you stop implementing, then seeing it go away?
No, so just overall as athletic trainers, are we really treating or are we really implementing tertiary prevention? From my experience, I feel like sometimes we treat and we feel like their issue goes away, so that's the treatment, or is it really just tertiary prevention that's not truly gone? Is the majority of what we do tertiary prevention or treatment?
That's a good question. I want to say most of it is probably tertiary. At least I feel that way. I think we do. I don't think we do enough screening to prevent, injuries from happening. I know that we do FMS, and but we kind of hand that over to strength and conditioning so that they can implement those correctives into warm-ups. But yeah, for the most part, unfortunately, I feel like I am doing mostly, cleanup, and am doing, trying to help them recover. I mean, there's an aspect of it that I think, we're trying to prevent further injuries. So like, with an ACL reconstruction, we have all this research to show, how to manage it, and then what you should work on as far as like, quad hamstring strength, and hip strength, and all these other things that we should do to prevent an ACL injury from occurring again. But yeah, I am kind of sad to say, personally, I think I'm not doing a whole lot of secondary unless, like the prompt detection is kind of getting me to think, like, if I'm, doing a treatment on one person and I notice like, yeah, like your hip flexors are really tight, like we should probably, add in some core rehab and then do that. And then I kind of try to explain to them is associated with low back pain and things like that. And so it's not really intentional detection, but it's kind of just, I happen to notice it while treating something else. Or if somebody says, hey, like my low back's kind of been hurting, and then I kind of go into more secondary prevention.
I'm just a thought in terms of tertiary treatment versus tertiary prevention versus treatment. I feel like trainers of physical therapists, athletic trainers are the main difference from what I see between physical therapy and athletic training is athletic trainers are, I guess, doing more tertiary prevention because athletes are being active. You're trying to maintain them doing their sport, making the injury not as prevalent as it should be so they can continue competition. But I guess in physical therapy, when you're not working with athletes all the time, one post-surgical only or elderly is not really that active, I guess they will be more treating more than tertiary because the patient's having the rest time to get better and I guess the rest time to eliminate the actual disease. Just a thought.
I sort of think, as athletic trainers, like we're always, out there just waiting for something to happen. I remember when I was working sports, I'm just sitting there and, if nothing happens, I mean, you consider it a good day. Really not doing anything. You go clean the athletic training room, you go back home. And my experience working with physical therapists, it's just getting them back to a base level of living where they can do activities of daily living. Now, did they take care of the disease? They take it away. Say if someone had a frozen shoulder, yeah, they can move their shoulder, but did they correct anything for it, or did it just go away? We read in some of the stuff in class, if somebody has low back pain, within 6 months, it's probably going to correct itself. So did your interventions actually work? And I think that's where practice-based research comes back into play. That is a way to quantify and actually see, hey, what are we doing? Is it working? Yes or no. So I think, yes, we do work with athletes and we're waiting for something to happen. We try to keep them going. But my experience with physical therapists is they just get them back to the ability to live somewhat of a normal life with that one.
My entire practice-based research project is looking exactly at this. I'm using FMS and quality of life and seeing how those measurements and perceptions affect injury rates in collegiate equestrians. And I've only been doing it a few months, but I've definitely started to see the effects of all of that. And we've talked about prom use and crom use and all that, and being able to pull from that definitely has affected in a positive way, the athletes that I've seen. And I think that that's a good point, that it's a matter of kind of looking at everything you have at your disposal, kind of jumping off from there and just playing with it a little bit. I don't think there's necessarily a right or wrong answer to this. That's, I think, why Brittany's question is so tough to begin with.
Yeah, and just adding like a little bit more, I'm sitting there thinking, traditionally athletic trainers, if you work Division II, Division I, Division III, like you may not have much time to add to other things. So the profession itself breeds this just reactive nature, because you really don't have time to sit there, plan, and do anything else. And I think, as we move forward in the stuff that we've covered in this program, it looks hopeful. I think that we can do a better job, and it may just be the fact that we need to stand up and say, hey, we need more time. We need to look at this. If you really want us to provide the care that we can, give us the time to do what we need to do.
Absolutely, Justin. That was a good point. Does anyone else have anything else they'd like to add on this conversation? Okay. Well, thank you very much all for watching. Again, we are Indiana State University students in the Doctorate in Athletic Training program, and thank you very much for watching.